Thank you and very good morning to everyone. I must thank the organizer for giving me this opportunity to conduct this session. From bleeding to thrombosis, that is what we are right now going to discuss, and we have an eminent panelist with hematologist and also general physicians, cardiologists, nephrologists and all. So probably a very good discussion should be there. Prescribing and monitoring anticoagulations in a practical approach, because most of the time we get those patients who needs anticoagulation, who needs continuation of anticoagulations, and we need to modify their anticoagulants that they are on according to the different clinical scenarios. So we have all our panelists, I welcome all of them. So before going to the proper discussions, just recapitulations of the coagulation cascades there are a lot of factors that gets activated one by one, ultimately develops fibrinogen to fibrin, and during a breach in the endothelium, there is initial activation of the intrinsic pathway leading to formation of small amount of thrombin, which leads to activations of the intrinsic pathway with the factor 8, factor 9, factor 10, and ultimately formation of thrombin burst, which leads to development of fibrinogen converting into fibrin, and that fibrin mesh ultimately leads to formation of the coagulations. And in this pathway, there are different factors or different agents are there which can act on different pathway, and thereby they can decrease or they can stop this coagulation cascades. So we have heparin and low molecular weight heparin, vitamin K antagonists, that is warfarin, direct thrombin inhibitors, and factor 10A inhibitors that are being used nowadays for a lot of patients. So with that, we'll start with our discussion. So we have a patient, this is a 46-year-old female with a diagnosis of CA cervix, recently diagnosed. Patient is also a diabetic on oral hypoglycemic agents, and now developed a swelling and pain in the left lower limb, a whole limb swelling. So this is the picture of the patient where she has a left lower limb swelling, which is also painful, having a redness and having some shiny skin over it. So for Dr. Dubey, if I can ask you, how will you proceed for the diagnosis in these patients regarding the thrombosis?
I think the underlying thing is that she has a CA cervix. So it's an active disease. Second important thing is there is a swelling and involving the entire lower limb. So with the two things, if you look at, the possibility becomes, the deep vein thrombosis becomes a very, very close differential. Now, second is differential is going to be cellulitis, necrotizing fasciitis, but for that we expect some amount of fever, some amount of toxicity. So that's very low probability. Third possibility is lymphedema, CA cervix, she has not received radiation, she has not been operated, so lymphedema becomes less likely. So my closest differential is going to be deep vein thrombosis. Now if you look at the recommendation wise, setting is important. Setting of immobilization, setting of surgery, setting of malignancy, and with this, clinical examination is showing the entire lower limb involvement or calf swelling increase of more than 3 centimeter, and if there is a tenderness along the veins, that is another point in favor of deep vein thrombosis. So this is a well score what has been described. Where the points has been given. If the point is more than 3, then it's a very high possibility. But if you look at very closely, if you think of alternative diagnosis, then it is a -2 point. If there is a single risk factor, then you have to think of DVT. So this is what the well score is all about.
So very well described that we do a probability testing by the well score, and if we find that the probability of thrombosis is high, then we can directly go to the Doppler study, and otherwise we can do a D-dimer for our exclusion. If we have any doubt, we can do a D-dimer. If D-dimer is normal, then we can very well exclude the diagnosis. Otherwise, we can do a D-dimer. We can do a Doppler study. So In our patients, there was a Doppler study done, and it showed intraluminal thrombus in the common femoral vein, superficial femoral vein. So diagnosis of deep vein thrombosis is there. So what will be the choice of anticoagulant in these patients when we have a patients of a CA cervix with a DVT? So Dr. Aniruddha Dharmadhikari, if you can elaborate us on what is the first choice of anticoagulant in these patients?
In such patients, we have to start immediate anticoagulation. Warfarin will take some time to act. So we choose between low molecular weight heparin and the novel oral anticoagulants. Creatinine clearance will play a very important role in deciding whether we start with DOAC or we start with low molecular weight. As also the age of the patient, the body weight, and the liver function tests. Because if the creatinine clearance is very low, say less than 15, then it is a contraindication for DOAC. If the liver functions are deranged, according to a Chuk-Childs classification, then again we have to give DOAC with caution. In such patients, low molecular weight heparin would be preferable. For the first 2 to 3 days, we give low molecular weight heparin or DOAC, and then overlap it with warfarin, and after 3 days we can discontinue the heparin or DOAC and continue with warfarin.
Yeah, that is very well said, because different scenarios, according to different scenario, like the renal failure or the liver disorders, we can choose the warfarin or DOAC. And recently, actually previously it was said that in patients with active cancer, low molecular heparin was preferred, but nowadays a lot of studies have shown that both the direct oral anticoagulants and the low molecular heparins are more or less similar, so we can use both. And in these situations, we need to counsel the patients regarding the pros and cons about different agents, and accordingly we can choose one of them. So I will ask the Dr. Devgaonkar to how you prescribe the direct oral anticoagulants. As we have said that in these patients we have decided to start with dabigatran. So how will you go for prescribing that medicine?
So basically, I'll speak from the perspective of a nephrologist. So most of the studies that have been conducted with NOAC, that is novel oral anticoagulants, they have not included patients with a GFR of less than 30. So whether to give NOACs in patients with a GFR of less than 30 is very controversial. Basically, all the NOACs have renal clearance. So the highest renal clearance will be in dabigatran. And I think rivaroxaban has around 50% of renal clearance. And the safest from the point of view of kidney is the apixaban. So apixaban has a renal clearance of almost 25%. So above a GFR of 50, all the NOACs can be given with a regular dose, as you can see on the screen. From 15 to GFR of a 15 to 50, usually the recommendation is that the dose of the NOAC should be halved. And below 15, current recommendation is not to use the NOACs. But if you want to use some of the novel oral anticoagulants, the preferred one is apixaban, which can be given in half dose, that is 2.5 milligram twice a day.
Yeah, that's very informative actually. For both the renal and the hepatic, dose modifications required sometimes for these newer oral anticoagulants. And there are also different drug interactions, though for the newer oral anticoagulants, drug interactions are much less. So we can use or we can choose our anticoagulants according to the different drugs that patients are receiving. Any comments about IVC filter? Dr. Dharmadhikari, if you can say something. Whether use IVC filter in this setting?
If it is the first episode of DVT, an acute DVT, then we just treat the patient with anticoagulation and not do the IVC filter in the first episode. If there is recurrent episodes of DVT, then we may consider IVC filter.
Yes. So for the juniors actually, the IVC filter is generally not required in acute settings. Most of the time the oral anticoagulants can take care of it and can stabilize the patients within 3 days. Even IVC filters can actually cause a thrombus. So sometimes when the patient requires anticoagulations but cannot be given because of the contraindication, because of the surgery, recent surgery, or because of some active bleeding, then we can use even a retrievable IVC filters, which can be used temporarily and can be taken out after the trigger or the risk factor is gone. So SCB guidelines also do not recommend to use the IVC filters. So in our patients, the patients continued on dabigatran and the pain and swelling is reduced, but the patient is concerned regarding progressions, whether it is working well or not. So Dr. Nishant, if you can enlighten us about how to monitor whether the patient is doing well or not.
So for DOACs, the newer anticoagulants, the major advantage why they are being preferred is because they do not require such stringent monitoring as we do in warfarin. So in DOACs, if the patient is on dabigatran or rivaroxaban, then you don't really need to monitor any PT or APTT. Only reason when you need to monitor is when the patient comes back with a bleed, when you need to know whether the anticoagulation is contributing to the bleed. In that setting, for dabigatran, prolonged APTT will tell you that there probably is a role of the anticoagulation, and for rivaroxaban, PT would help. But otherwise, if the patient is doing fine, if there's no need for monitoring. For warfarin, as we all know, we've been using it for a while, you need to monitor INR till the patient achieves a stable INR for the first few weeks, and then you can monitor it at each OPD visit. So DOACs, the major advantage is you don't need to monitor. You need to monitor if the patient has bleed, renal failure, or some reason where you think that the DOAC is not working.
So that is true, that most of the time we use DOAC because these do not require any monitoring, and actually there is very little availability of tests that can actually done to monitor this newer DOAC, and anti-factor 10A is one such, which is also not available in most of the labs. So I'm coming to the Dr. Soikat. So these patients actually recovered well, and after around 1 month, the pain and swelling has subsided, but the medicines that is given, that is quite costly, so she wants to convert it into a cheaper version, that is warfarin. So I would ask, how will you prescribe this switching from dabigatran or from rivaroxaban to warfarin?
So first thing I would like for my patient, they don't want to change at least in first month, because the chance of rethrombosis is most common in first month and first 3 months. So it is very important to maintain proper anticoagulation in first 3 months. So it's always better than we have the same anticoagulation continuing. But sometimes it's not possible. Patients have their preferences, cost matters. Then we can change. And obviously, for cancer-associated thrombosis, we don't have much data about dabigatran. Usually for NOACs, we use apixaban or rivaroxaban. If we are using dabigatran and you want to shift to warfarin, like warfarin needs some time to get an INR of 2 to 3. So if a patient having normal renal function, we give 3 days of overlap at least to get the INR of 2 to 3, then we stop the dabigatran. But if the kidney function is poor, like it is less than 30 creat clearance, then we give 2 days of overlapping. Below 30 creat clearance, I usually don't use NOAC or DOACs. So if the situation is reversed, like some patient is on warfarin, they want to shift to any NOAC before, because they have many problem. Like in many stations, many cities, they don't have good INR, good lab to produce good report of INR. So it is very difficult to get INR every monthly. So for that case, we can stop the warfarin whenever we have an INR of less than 2 and start a NOAC or DOAC.
So we have to keep in mind that warfarin has a long half-life, so we need to overlap whenever we change from dabigatran to warfarin for around 3 days, and even when we change from warfarin to dabigatran, we have to give a time for the warfarin to come down and INR to come down below 2 before starting dabigatran.
But situation would be a bit different when we are not using dabigatran. Like if you are using apixaban or rivaroxaban, yes, they increases INR. They are factor 10 inhibitors. So if we are monitoring the INR with them, it would not be appropriate. So for them, we just stop the apixaban or rivaroxaban. We start low molecular weight heparin, we start warfarin at a time. And we monitor the INR. When it's more than 2, it's fine. We stop the other parenteral agent.
Yes. Very right. So this patient is now stable on anticoagulants, but since he is having CS cervix, he needs a surgery. So now these patients need to have a perioperative anticoagulation management, and the hematologist is called for that. So I will ask Dr. Neha, what are the factors that will you first decide to determine your strategy of anticoagulation?
The factors that we take into consideration before deciding regarding the anticoagulation peri-operation are the type of anticoagulant the patient is currently on, the type of surgery that the patient would be undergoing, what are the patient factors which predispose him for excess bleeding or thrombosis. So as in our patient, the patient was shifted from dabigatran to warfarin, and now we have to take this patient for surgery. I would like to stop warfarin 4 to 5 days before surgery, because it takes 4 to 5 days for the effect to go, and bridge for this 4 to 5 days with low molecular weight heparin. And we generally stop, we withhold the dose of heparin a day prior to surgery. Then after surgery, once the local hemostasis is achieved, and the local area is fine, we restart on low molecular weight heparin plus warfarin, and after 3 to 4 days we can then stop heparin and continue on warfarin. So as per this patient, but the scenario is different in each case, so we have to consider all these 4 factors before deciding.
Yes, right. So we can go for a bridging therapy for these patients, but we need to determine the different risk factors. So I will ask Dr. Nisat Jindal, because we can have a strategy like no stoppage of anticoagulants, continue anticoagulant and do the surgery over it. We can have stop the anticoagulants, no bridging, and we can restart anticoagulation after surgery, and we can use bridging anticoagulants in different scenarios. So Dr. Nishant, if you can elaborate in which situations, which of the strategy you will try?
So like Dr. Neha said, you have to look at each patient individually. So in the patient like this, because cancer-associated thrombosis is one of the major risk factors for extension of thrombosis and rethrombosis. So in a setting like this, you want the patient to be anticoagulated at all times, at least till the time the patient has active malignancy. So like if the patient is on warfarin, you would discontinue the warfarin, start a bridge therapy with maybe low molecular weight heparin, take the patient up for surgery and start anticoagulation as soon as hemostasis is achieved. This is because there's a high risk of thrombosis and there's a high risk of bleed. In a setting when there's a very minimal risk of bleeding, like a dental procedure, you don't need to stop anticoagulation if anticoagulation is important. So it basically depends on the type of surgery, the bleeding risk and the thrombotic risk.
So that's right. Just to emphasize that some of the procedures that do not need any stoppage of anticoagulations, like some cataract surgery or dental extraction, some dermatological conditions that can be treated without interruption of anticoagulations. When there is a high bleeding risk, then we need to classify the patients according to the thrombotic risk. If that is a high thrombotic risk along with high bleeding risk, then we need to do a bridging. But if the thrombotic risk is low with a high bleeding risk, we can very well stop the anticoagulants and we can restart the anticoagulations after the surgery is over. For the moderate risk, there is a very dilemma because we can go any way. But the recent study with the bridge trials, that they have shown that bleeding risk is much higher than the thrombotic risk in initial postoperative periods. So that's why no bridging is much better than going for a bridging therapy, because with the bridge therapy, chance of bleeding is high. So even in the immediate postoperative periods, chance of bleeding becoming high, so we can eliminate this bridging therapy in a moderate risk group. So in our patients already been discussed that we need the bridging therapy, and that is how we go for bridging therapy. That means around 5 days back, we stop the warfarin. We start with low molecular weight heparin, and around 24 hours before the last LMWH dose is given, and after that, after the surgery, around 12 to 24 hours, when the hemostasis is achieved, we can restart both warfarin and low molecular heparin, and once the INR again goes up to above 2, we can stop the low molecular heparin. That's how we continue. So in these patients, patient underwent surgery well because of our hematologist who took care of the patient very well, and now again continued on warfarin, and patient is now receiving the adjuvant chemotherapy. Now she developed a sudden onset GI bleeding with a hemoglobin of 5.8 and a PT INR was 4.8, 4.5. So this patient is having a GI bleed. So Dr. Saikat, if you can elaborate, how will you treat in these patients?
Like this is a critical scenario. So hemoglobin is 5 and there is continuous bleeding. We need to stop bleeding. I would obviously stop the anticoagulation warfarin. If like FFP is immediately available, I would give FFP. If with warfarin, we are inhibiting 4 factor 2, 7, 9, and 10, and we have 4 factor concentrate available in India is octaplex. Usually big hospital at least keep few vials available. So if it is there, we will start octaplex 1000 or 2000 unit 4 factor PCC. Because FFP needs time, you will make a requisition. Even thawing of FFP takes 20 minutes. So if the bleeding is active, it will always better to give 4 factor PCC. And we'll stop bleeding. Obviously, we monitor hemodynamics. We'll give PRBC. It is for this patient. Warfarin for other drug like dabigatran, the company Pradexa, which produce Pradexa, they usually supply trastuzumab, but it is not always available. And for other factor 10A inhibitor, Apix-7 and Rivaroxaban, in India it is not always available, andexanet, which is the reversing agent. So it's a bit difficult with those agents.
Yes. So important one is when there is bleeding, we need these reversal agents, but when there is no bleeding, we may not need to give these reversal agents. We can very well, for warfarin, we can go by vitamin K, and we can decrease the INR, and after that we can restart the warfarin at a lower dose. So I would also ask the other panel members, so how you go for restarting after the GI bleed? How you restart the anticoagulations? Anyone from the panelists? Dr. Dubey?
As far as the GI bleed is concerned, I think endoscopic finding, if there is an active bleeder and which can be taken care of, and the chances of rebleeding is, as per GI opinion, is less, then I like to start as soon as possible because she has a CA cervix and she has a DVT. Regarding most thrombotic events occurred between 2 to 8 wickets of after stoppage of anticoagulant therapy. So I like to start as soon as possible in the GI bleed. Now the second question comes about the intracerebral bleed, and the next comes about the trauma, subdural hematoma, and the patient coming with the trauma. So I think those situations are very tricky situations, and many times we have to go with the neurosurgical opinions. And in that case, there is one good trial of 490 patients. So what they have found, if there is a intracerebral bleed, and if there is within 24 hours size of the bleed increases, if there is a subdural bleed size of more than 10 millimeters, these are the individuals who are going to bleed more. So those situations become a difficult situation. But again, the moment the things are taken care of within 2 weeks, one should start. Next comes about the non-volatile atrial fibrillation. There are definitely the guidelines which Aniruddha can talk about that. And stroke again becomes another domain where things are difficult to decide. But again, earlier we start, the better we are.
Yes, that's very right. There is actually no definite guidelines for how to restart anticoagulations. There are few soft points like you should start the GI bleed. Actually, recurrence of GI bleed occurs within the first 2 weeks, and the recurrence of thrombosis occurs during the 2 weeks to 8 weeks. So it's better to start as soon as possible, but at least after 7 days. And also, if we can cut off some of the anticoagulants and antiplatelets, if we can stop the antiplatelet therapy along with anticoagulants, that can be helpful. and sometimes it becomes very difficult because patient may have a recurrent GI bleeding, and at that times it is very difficult to start with anticoagulations, and this has shown that the newer oral anticoagulants have a higher propensity to have a GI bleed, so warfarin probably are better options. So
I would want to add one point that the indication for which we are giving the anticoagulation, that is also important. Like we are treating a patient for AF with anticoagulation and a patient who are having mitral valve, mechanical device in mitral valve, those are different because the mitral valve device, these are very high probability of getting thrombosis. So usually we don't delay with 2 weeks, 3 weeks for those patients. When the bleeding stops within a week, like after a week, it is better to start for those patients. For a patient, probably we can wait for 3 weeks, 4 weeks also for some cases.
Obviously, because in the settings of whether there is a prophylaxis or there is a therapeutic dosing, that is also important. In therapeutic settings, we should not wait for more than, probably more than 3 days, also difficult. So this patient is actually had a GI bleed, but that subsided, but patient is now having a platelet count of 35,000. Mind it, the patient is on chemotherapy. So I will ask Dr. Nishant also, how will you modify this anticoagulant in these clinical settings?
So before I answer this, I'd just like to point out that you had shown it in the slide that FFPs don't really work in newer oral anticoagulants. So there's no point in giving it if you have a bleed. Second thing I think it's important to understand is if a patient has a GI bleed, I think it's best to give anticoagulation with a low molecular weight heparin or a unfractionated heparin because in our setting that's the easiest to control because it has a short half-life before you go on to an oral anticoagulant. So UFH has a very short half-life and the effect doesn't last for too long if you must give anticoagulation. To answer this question, like Dr. Uday had also pointed out, so it's important to titrate the risk of bleeding versus thrombosis. In this patient, if the platelet counts are low on adjuvant chemotherapy, say 3 months after the episode of anticoagulation, you can wait for the platelets to recover and then give anticoagulation for 3 or 4 days because the platelet thrombocytopenia is not going to last for too long. But in a patient who has had an acute DVT in the first few weeks, like Dr. Shekhar said, the risk is maximum, then you would need to give either a lower dose of anticoagulation, maybe 50% of the dose, or you could give platelets, bring the platelet count above 50,000 and then give full dose anticoagulation. Again, you have to balance the risk of thrombosis and the bleeding.
So that's right. We also need to look into the cause of thrombocytopenia because in the settings of cancer, it can be because of the metastasis that leading to thrombocytopenia. Then it is very difficult to improve the thrombocytopenia in a very rapid way. So in those situations, we may need to modify the dosing. Otherwise, if it is because of the chemotherapy, then we know that thrombocytopenia will improve after some times. Then we can continue with the platelet transfusions and full dose of anticoagulations, or we can use the L-Thrombopag or Romiplastim in these settings to increase the platelet counts so that we don't need to modify the anticoagulations. So this actually more or less completed operative interventions and adjuvant chemotherapy is completed, and now the patient is declared cured. So I will ask the panelist, how will you go for prescribing the anticoagulations, for how long, and any other parameters to monitor?
Possibly this is a cancer-associated thrombosis, and it hasn't got other provoking factors. So it's a unprovoked cancer-associated thrombosis. So at least 6 months of therapy is needed. But when cancer is active, like when cancer is metastatic, we need indefinite anticoagulation, and we usually don't put a stop date. If a patient is not bleeding, bleeding risks are low, you usually continue for our cancer patient. But if we had a surgery for cancer, it is like stabilized cancer is not there, in hematological cancer, if it is CR, complete remission, then we can stop those anticoagulation. For other cases, like which are not cancer-associated thrombosis which are having in other patient, but not provoked by any factor like surgery, immobilization, trauma. Those unprovoked cases of thrombosis, we usually give antithrombotic for at least 6 months, and many of those patients got indefinite anticoagulation. We can do D-dimer, we can again check for like recanalization of the vessel, but those are not definite. Like we can't say that if the recanalization has happened already, that will not be thrombosed again. But if the D dimer is low and there is complete recanalization, chance of thrombosis, and obviously if the patient is female, chance of rethrombosis and recurrence is less. So we can stop the drug more confidently.
Yes. That's right. We treat at least 3 months for all patients, and after that, if it is an isolated distal DVT or a reversible cause is there, then we can stop, or we can go for a thrombophilia testing and see whether there is any thrombophilia present or not inherent. If there is unprovoked DVT or if there is inherent thrombophilia, then we can go for a prolonged therapy. And in case of cancer, if there is active cancer continuing, then we can go for a indefinite therapy for the anticoagulations. So we'll end here, and also from the audience, if there is any questions or any confusions regarding anticoagulations, since we have some time. We are actually out of time. Thank you, and thank you the organizer for giving me this opportunity, and thank you the panelists for giving us such a wonderful inputs. Thank you.